So I think it's time to start off this session and welcome everyone to this session, which is about how to prevent further diseases by preventing the first one. My name is Daniel Ågren. I work at Roche and I have the pleasure to moderate this session. This is an area that's not often prioritized by healthcare and societies, and most of the resources are often focused on reactive healthcare. But if we should be able to have a good healthcare in the future, we need to start using the resources more efficiently, and prevention gives much more value per spent resource. And according to OECD, every euro invested in good preventive measures gives back 6 euros in societal value. Another important aspect is when a patient gets one additional disease, it often creates a ripple effect, giving even more diseases. So if we can intervene as early as possible, we can stop this domino effect, and then we can save lives, but we can also save societal value. So that's what I hope we can discuss during the coming 48 minutes, how we move from a more reactive healthcare system to a preventive system with the patient in focus. And with that said, I would like to invite Ylva Trolle Lagerros to the stage, where she during the coming 15 minutes will give an introduction to this topic. And then I will invite the rest of the panel for a discussion here. So Ylva is a professor at the Karolinska Institute. She's also a specialist in internal medicine, working with obesity at the Karolinska Hospital. So kick it off, Ylva.
Thank you. And thank you for inviting me to talk here today. So I'm actually sharing my time between being a clinician, treating patients with high BMI, with obesity, and then doing research. Well, what about the risk factors that we are talking about here to prevent further diseases? What risk factors should we think about? Well, if we look at the major risk factors in our part of the world, here we have the 8 most important risk factors. It's smoking, high blood pressure, high BMI, high blood sugar, alcohol, kidney disease, high cholesterol, and air pollution. And if you look at those, most of them are really due to our lifestyle. What we eat, what we drink, what we do in our lifestyle. One major risk factor, of course, is smoking, if you look at the Northern Hemisphere. But if you look in Sweden, we have been pretty successful in working with smoking and working with prevention in terms of smoking. Currently, between 5 and 6% of the Swedish population is smoking every day, which is a good, well-done prevention for smoking. And if you look at the proportion of cardiovascular diseases attributable to lifestyle factors, you can see that smoking is actually down here compared to the risk of unhealthy eating habits in terms of ischemic heart disease and stroke. So diet is really one of our main factors that we need to work with for the future. And if we look at the recent report, we have a downward trend in our diets when it comes to fish, when it comes to fruit and berries and vegetables. The only thing that goes straight up, that's sugary beverages. You could believe that this was due to the pandemic, but if you look closely, the pandemic was here in the middle, and this is what happened after the pandemic. So do we compensate this eating with physical activity? I'm sorry to say no, because here in Stockholm, when they did a survey, how likely are you to take the car, bus, bike, walk, or other? You can see the car, that's the red bars. So 29% chose the car for distances below 1 kilometer in Stockholm, where it's probably most of the times it's quicker to walk than taking the car. And we are sedentary. 1 in 4 Swedes report being sedentary at least 10 hours a day. So you go back to your own life, how many hours are you sitting? But I think the worst thing is, look at this. 4-year-olds spend more than 8 hours a day being sedentary. That's our 4-year-olds. I think it's one thing that we are sedentary, but actually if you compare people in their 80s to teenagers, our Swedes in the 80s, 90s, they actually move more than our teenagers. And of course, if you put all this together, the diet and the inactivity, well, of course, this is the result. So here we have the trends in obesity among adults, pregnant women and children in Sweden. And currently we are here. 18% of the Swedish population has obesity. And what is then that? That's a BMI above 30. So if you have BMI above 30, that's when you are classified as having obesity. And if you want to sort of get some kind of idea what is that, it's if you're 170 tall and you weigh more than 90 kilos. So then you have some kind of sense for it. So this trend is just going up and up and up. And I think it's even more worrisome that this green line, that's the pregnant women in Sweden. And we know that obesity among pregnant women is a risk for problems during the pregnancy and problems during delivery. Are we alone with this kind of figure? No. So what we believe, what the prognosis for the future, the global future, is this: 750 million children, adults will have overweight or obesity by 2050. So here we can see that the increase during those years between 1990 to 2021, basically here we are. But as you see, the North African, Middle East, Latin America, Caribbean, and countries with high income have a very steep increase. And these are children and young adults. Often when we talk about obesity, we talk about the costs for healthcare. Currently we're talking a lot about the cost, the potential cost of treating people with obesity with medications. But if we really look at where are the costs for obesity in Sweden, or overweight and obesity, it looks like this. So the big chunk here, that's not the healthcare. That's actually productivity losses. 71% of the costs that are coming with obesity is loss of productivity. 21% is healthcare cost. And I think this is something we really need to keep in mind. Where are we? What is really costing? Where we at the Center for Obesity, you can refer patients from the age of 16. And we know from research, Swedish research, that if you have obesity when you enter gymnasium or high school, you're less likely to finish high school than kids that are normal weight. And this is independent of the socioeconomy or the education of the parents. So this is purely due to your size and the fact that you're bullied. But not only bullied, it's also because like we have patients that are in the education of building houses, bygganläggning, and if they have a high BMI, they're not allowed to do some of the different things in their practical skills that they have to train, like being high up on building houses and so on. So they will not get full grades for that course. They will graduate without the full gymnasium. So there are a number of things that happen in this group that makes them they're not competitive when it comes to getting the first job. So I think this is something that we might also discuss later on. So we need to break this curve, and I just want to give you an example. Like a typical example for this is pre-diabetes. Pre-diabetes is something that comes very slowly. You don't really notice it. It takes many years. You have increasingly high blood sugar levels, but you feel fine. And then it's increasing. Oh, you're in the risk zone. Maybe your healthcare provider finds out that this is a pre-diabetes. Maybe not treated. You're told to go home and take some quick walks in the evenings, which might or is less likely to happen. And after a number of years, you end up with diabetes type 2. Once you have this disease, well, we know that the risk of a myocardial infarction is 3 times as high if you have diabetes type 2 than if you don't have it. And when you have a diabetes type 2 and a myocardial infarction, you have twice the risk of dying from that myocardial infarction. So here we have this curve, and what we want to do is to break the curve so that you don't keep going all the way up to diabetes type 2, to myocardial infarction, and so on. Keep this figure, this curve in mind, and we will look at another curve. So this is a weight curve from one of the patients that was referred to us. And it's small, but here you can tell he's born 2008. So that's the first weight, was 2008. It was 3.5 kilos. And then you can see every little cross, that's when he's being weighed in school. At the age of 9, healthcare reacts and say, hey, this is not going the right direction. So here you have a number of small, that's where he's being weighed. So obviously healthcare is really trying here to help the family. They give him a dietitian, or the family is being treated by a dietitian. And the goal here is to keep the weight and then wait for the length to sort of increase so that BMI is being decreased. Anyway, here he's 12 years old and they're losing it. And during teenage years, he's just increasing his weight. When it comes to us, he's 16 years old, and here is just one of the blood tests that they were taking. So here you can see an insulin of 34, that's an increased insulin level. That means that he, at the age of 16, has a body that is resistant to glucose. So it's already now starting to push out insulin because it feels that, hey, this insulin is not enough, I'm having high blood sugar here. So we know at this age, 16, this boy is on his way up here. He's already unhealthy with an increased risk. And if we don't help him to lose weight and get a different curve, he will end up with diabetes very early in life. And the association between obesity and BMI is, we know that since a long time ago. This is a study published in 1995, and here you can clearly see that when BMI is increasing, so is the relative risk for diabetes type 2. We know that for decades we have known that. So really what we need to work with is that we have this boy, or we have those patients, and we can give them the knowledge. We can give them their medical data. Hey, this is your insulin level. We can help them with lifestyle, talk about the risk profile and so on, and give the patients all the data. But that's not enough. That won't do it. You also need to get the patient to understand, what does this mean to me? hey, I'm 16 years old, I have high insulin. What does it mean? So we need to have this work together with the patient. It's not enough just to know something. You need to understand what it means. And you also need a plan. You need to have a plan. How do I do now? And that's where we really need to help and support our patients. It's not enough just with the knowledge. You need to give them a plan and give them the support to succeed with it. Because if you're not there, if you're not giving them the tools, we won't succeed in turning this curve. Well, finally, I was asked before this speech to also give an example of can we succeed with this? I know, I mean, we wouldn't even have a clinic if we didn't see that we are succeeding. And we are clear, we have so many patients that are doing very, very well. But can you see this in a bigger picture? Can you see it even in a country? We cannot yet see a change in the Swedish, how common it is with obesity. But when something like that happens, it's huge. It's huge news. And that's what happened in December last year, when obesity, the percentage of the number of people, or the percentage of people with obesity in the US actually decreased. So when this happened last year, that was world news. Because as you can see, it just increased and increased and increased up to 39.9% of the population having obesity. And then here is the drop. So it's possible, but when it happens, it's great news all over the world. And I will stop there, because I know we are having a panel debate, and I will let you others talk too. But thank you.
But I think that was fantastic and really, really, really inspiring. And I have a question for you as well. So before we bring up the panel, what's the single biggest clinical hurdle to get these new preventive innovations to the patients who need them now?
I think the biggest problem might not be I think we have the innovations. We know how to work preventive, but we have to integrate that. It's not the innovation, it's the implementation we need to work with. That's what I think is the issue now. To have prevention integrated into the clinical work, so it's not an exception, it's sort of a rule in how you do it. And I am a bit sad to see that there is an ongoing discussion where a lot of clinicians tend to think that prevention, that's something for everybody else to do. That's not, we are treating sick people, so we can't treat people that need prevention, they need treatment. And I think that's a very short-sighted way to see it, because there is also a picture of that all those 18% will come to the healthcare and demand obesity care. But they're already there because of their needs for infertility, for psoriasis, for diabetes, for a number of different things. So I think what we need to do is sort of to switch. It's not the innovations, it's the implementation that lacks.
That's good. Implementation.
Yes.
With that said, I would like to invite the rest of the panel to the podium here. And that's Elisabeth Dupont from IDF, representing the patient voice in the diabetes space, and Brian Kennedy from GAfPA. You're an expert on global patient access and on kidney health. So, I don't know how you want to sit. So, you can sit there. Yeah, so when you listen to Ylva here, what's your perspective on this, Elisabeth? You can start. What do you think from your perspective?
Wow, I think I would need the rest of the panel discussion to react on what has been said. I think there is obviously, as you mentioned it a few times, so much link between diabetes and obesity everything was so relevant. And I think from our perspective, what's really worrisome, and you also highlighted it, is the fact that because of obesity and overweight in younger children, the type 2 diabetes is developing at a very early age, which wasn't the case before. So the healthcare system is not prepared to that. And we also know that because these children will live with diabetes for a way longer period of time, the likeliness,
they're likely
they are more likely to develop, all the complications that go. So in fact, when you were mentioning about the prevention of one disease, being in this context, I suppose, obesity, we see obesity prevention and management as the best prevention for type 2 diabetes. But then when people live with type 2 diabetes, it's so important to make sure that these are also well managed to prevent the others to happen. You mentioned cardiovascular disease, but there is also kidney disease, there is also diabetic retinopathy, people will get blind. So really addressing the root cause of the evolution of many of the conditions, we know that not all people who are obese or overweight will develop type 2 diabetes, but we also know that 80% of people living with type 2 diabetes live with overweight and obesity. So incredibly important to address obesity.
Yeah. No, but I think that's a great perspective. And Brian, you have both. You have the American perspective, and you also have a global perspective, and also the kidney disease perspective. How would you elaborate on that?
I think the challenge in the space is really just how early can you go, because you looked at the various risk factors that exist out there. Some of which are controllable, some aren't controllable, at least by the individual. The environment they live in. There's a lot of different factors that drive that. But when you look generally what's happening out there, as economies develop, modernize, whatever it is, lifestyles are changing. The food that's being consumed is different, and the nature of activity is different, much more sedentary at the end of the day. And so when you look at the charts you had, and when you saw the rate of growth that was expected in Africa, Asia, low, middle income countries, in many instances, that's what's particularly concerning when you think about this at a global scale, because Europe, United States, we are where we are, and we can see what's happening. But when I look at the impact in those places, I'm sorry, I'm not broadcasting.
But I'm just curious what your take is there. How early can we go? Yeah. I mean, what's really possible, right, in terms of changing these things?
What I really think is that we, as it is now, we're leaving it to the individual to make those healthy choices every day, every time, every meal. But I think what we need to consider, need to work with is how can we go upstreams? Like, how can we build our cities? How can we make choices easier when you're in the store? How can you help people much earlier so that they don't have to make all the tough choices, that it's easier? If you have a safe environment, you can take that evening walk. But we have lots of areas in Stockholm where you would not take an evening walk. It's too dangerous. So I think we have to work much more on a societal level. And I mean, of course, when it comes down to the individual and the kids, you can start very early it doesn't even have to be a discussion with the kid. It can be with the family. Like in this family, we're just drinking water. That's not you don't need to discuss with the little kid. It's just that's the way we do it. We only have desserts on Saturdays. And to have all those healthy rules that make that you don't have to make a choice every single time you go shopping with your kid whether or not there will be sweets. It's just not done. So I think there are lots of things that can be taught to parents also, that we are kind of lacking that sometimes.
Do you think it's a lack of knowledge, a lack of will?
you know, sometimes we're talking about motivation, and the more I work with this population group, I think motivation was, you can read in medical charts, oh, the patient is not motivated. And I'm like, no, that's wrong. Because people are motivated, but they might not be in a position in life where they can do anything. They're too
They're
exhausted.
empowered to do something, yes.
Yeah, they're working 3 jobs. They're single moms. One of the kids is going through HD or some kind of neuropsychiatric check, and it's just too many things. And I can understand that this woman might be super motivated, but it's just not doable.
Yeah, I would tend to agree. I don't think anyone would choose, you know, to live unhealthy. I don't think that anyone would choose to put on weight that at some point become a stigma. So I believe that the environment really has to be looked at, and that's the very first step. And then, yes, there are new innovation and choices that can be offered and that can support. And I think you mentioned support a lot also in what you were saying. I think that's the next step, but let's also not forget about, you know, what is driving people into overweight and obesity, and then diabetes, cardiovascular, kidney, liver disease, etc.
And I'm also thinking, I mean, if you go shopping in Sweden, it's cheaper to buy a chocolate bar than a squash. It's cheaper to buy påskmust right now than it is to buy milk. How do you make yourself popular when you go home to your kids? Not with a squash.
Well, what do we do about that? Okay, so are we going to ban chocolate? Are we going to we give people information, they still make the choice of purchasing the chocolate over the squash, right?
Yeah, but I suppose
I look at what the culture, what goes on in the culture too. I mean, it occurred to me the other day, it feels like you've seen more people smoke in movies and television shows. And then I saw a news article saying Hollywood making tobacco glamorous again, smoking cigarettes glamorous again. And, you know, how is it at this point, given the history, what we know about smoking,
How is it
that
possible?
Hollywood is making that choice, right? Yeah.
I think we're moving back. When we had the discussion here, we talked a lot about the new innovations that are coming, and that this field is really, it's moving super quickly. And Ylva, we had a lot of discussions about this, that we are now getting more and more options. Things needs to be more individualized. I don't know if you want to elaborate a little bit on that. So many things are happening in this field.
Well, yes, I think we are as a physician, it's an amazing time to be working now, because we are much more able to look beyond one size fits all. And really personalize treatment. And we are getting even more and more of that. And also with the digital solutions, we will be able to help our patients with making this plan and keeping to the plan. So I think the combination of new medications, digital solutions, all those things are going our way and are being helpful to be able to target what is it with this patient in his or her life that we can help to make this plan and to make it happen. So I think it's a fantastic time, but we also have to, I think it is important that we also make this happen through the health system. If this is not being paid for, like if we don't have systems that pay the physicians or the healthcare personnel to work with this type of things, it's not going to happen. It doesn't matter how wonderful innovations we have, but if that is not a part of our system and it's not being reimbursed, it's not going to happen.
Yeah. No, but I think that's an important point, and that we have equality of care over the whole country. And Elisabeth, we discussed a little bit about early diagnostics and identifying patients early. I don't know, it's super important in diabetes and in pre-diabetes.
Yeah, indeed, and this is really something that we are very, very keen on making happen. we feel that, as you were saying, the earlier the better. You speak about early diagnosis, etc. So for us, and we know that as soon as blood glucose levels start, to fluctuate a little bit too much, it means that it's time to act. And you were saying it, at the beginning, you are in the curve where you think I'm fine because you do not have any symptoms, but your curve might already start, showing some dysglycemia. So there are nowadays these CGMs, the continuous glucose monitoring systems, that could be used as a prevention tool, as an early diagnostic tool before the condition starts setting in. So really, and why I feel it's not only a diagnostic tool, but also a support tool, because either you are someone who likes data, and then you see your data and you see that your blood glucose levels are at that level, etc., etc. Either you like, you're a visual person, so you just see the curve, and you really see, for example, at lunchtime, my peak was amazing, and I thought I just had some normal meal, and no, I was really out of range, and I just could see it. And I think if anyone had the opportunity, when you are in a high-risk group, if you start being overweight, if you have family history, so just at least for 2 weeks, having access to some kind of tools that would show you the impact of the stress, the lack of sleep, the food you eat, the physical exercise, you would start, and I think this is again, what you had on your slide, you would start to have the knowledge and the understanding. Not maybe enough, but at least you would understand that it's also on you to try to see what you can do, and then this is something that you can discuss with your healthcare professional, who can then, discuss any plan and any choice that would be, the one that is personalized. So this is one of, the thing that we feel would be really very useful in terms of early prevention and diagnosis.
Yeah, no, but I think that it was really clear on your slides also, Ylva. And if we move more into the societal value, I saw the costs often lie outside of healthcare and the values often come outside of healthcare. How should we be able to highlight that to the right stakeholders so that innovations and interventions are financed by the healthcare system in a good way? I don't know if you want to start with, you have an American perspective as well, so maybe you can.
I'm not here to say the Americans have it figured out in that regard, but I think excellent points made. We what works out there, right? So access to information. So as we digitize everything and the role that AI will play in helping us understand information, that could be empowering to people so that they do have more control over it. But I think we've heard that in a couple different panel discussions about the people looking for what they can trust. And one source of trust is where they have a relationship with their primary care provider that's built on trust in a way that, the advice that they're giving, that they will accept it and take it in. So when we talk about the early is better strategy, part of what we're talking about is there must be much more focus on primary care and what primary care looks like, whether you have to present at a clinic or if that's coming from other healthcare providers, not just your doctor, but being able to engage them in different settings, community-based care. And of course, in different countries, that can look very different based upon what the economic the status of the country is and the health infrastructure that exists. So I was in Rwanda last year for the NCD Alliance Global Forum and took the opportunity to tour the country. Out in rural Rwanda, went to a market where everybody comes a couple times a week to exchange goods, etc. And there set up in the midst of the market was one tent that was doing health checks. They were checking hypertension, right? So health, that's not the way we think about it here. I'm going to check my blood pressure, but we have to make it accessible at that level, meet people where they are, empower them with the technology that's going to allow them, those who are looking to be empowered to take control of their health, have that capability.
But I also think it is important to, I mean, if we want to see this happening, we need to not have the budgets on silos. So this is the budget for this primary care, but then we have a totally different budget for production and so on. We need to look upon prevention as something that also the gains are also a gain for healthcare somehow. So we need to look at the system from a different perspective, I think, because if we just keep looking at this is the budget and we just do those things, but then the gain is far out there, then prevention would always look very expensive.
Mm-hmm. I mean, think how little it costs really to manage hypertension, blood pressure, right? I mean, very inexpensive therapies to do that. But if we manage somebody's hypertension, maybe it keeps them from getting kidney disease. And if they don't get kidney disease, they don't end up dialysis or having a transplant, which are very expensive interventions at the end of the day. But nobody thinks about it in its totality. It comes down to, well, are we even paid to screen for hypertension, let alone that we're going to pay for treatment?
Yeah, so that's an excellent example of where it's super expensive if
when you get to the end.
It's cheap here and very expensive there.
Yeah.
So that I think that's really important, and I want to stay with this question a bit because I think this is really important that we need to be able to highlight the values and we need to be able to show them to the right people. So do you have any ideas how should we do this in a structured way, if we think about it from a let's say both from a local perspective but also from a more European or international perspective?
I think you said that the difficulty is that the budget are siloed, and that indeed the health budget, is not the one from the employment minister. So as you say, this is a systemic issue in terms of how government function. So I think it's already difficult to see the systemic within healthcare, but if we have to go further, I think it's important, and it's probably also very much the role of the patient association to show, that yes, in terms of healthcare, this is what we need, but what we need goes way beyond simply, the care that we need, and we need to have the road that are better designed and where we can cycle, where to have safe space. We have to have the same opportunities for employment, and then because we will be able to work better, we will be more productive, etc. I think maybe that's where also the patient voice may have some strong role to play.
Yeah.
Because that's something that that's something we clearly see when we have patients that have been on sick leave for a long time, or they never got a job because they go to an interview and they will not get the job if they have BMI 50, because most likely because the employer would say, oh, this is somebody who's lazy. He can't even lose weight.
Yeah, this is the stigma
The
thing
stigma
that
is
you mentioned
large.
bully, but it's the stigma is huge.
It's huge.
And
With this patient losing weight, the likelihood of getting a job is so much bigger. And I had a woman, she was on BMI 70. She went down to BMI 44. So BMI 44, you're pretty big still. She is now working full-time as a teacher. And she loves it. It's just fantastic to be out there. With 70, you cannot really even move. But losing weight to BMI 44, which most of us would think, oh, wow, that's quite a lot still. But she's working full-time. And that's what we can gain from working with obesity, for example, having people back in work, and that's a lot of money in that.
And that's also, I know that's not your question, but still, that's why I think that the new tools that we have are so useful, because it gives you, the help you need to start on a journey. And when you start and when you see that, you know, you make, you know, some success and you are able to do things, and then you are confident again in what you are, but also what you can give, and then you change completely the approach. And again, I think the innovation, one would work for someone, would work for someone else differently. You said it, there is no one size fits all. But now there are a number of options, and if people can avail themselves of one option that works for them, I think it's a huge success.
An example of that with innovation that works really well is that we have a number of usually guys that in their teenage years stop going to school. So they're not going to school, they're not working, they're not doing anything else but sitting at home. They're home sitters by the computers. We could never even get them to our place. They wouldn't leave their room. They wouldn't even have the money to go to us. Now we can reach them where they are. They're on the screen.
Yeah.
So we can work with them on the screen digitally. We have started sending scales to their address because they usually don't even have a scale. And then they're once a week sending in their weight. So that's what they have to do. They're using the chat function, sending the weight, and basically that's it. And by doing so, we have had a number of those boys that have lost enough weight to feel comforted to leave the room and to actually come out of the room, get out there in life, go back to school. So that's an example of how innovation can help us in healthcare, help these young boys, that the teenage guys, that otherwise they wouldn't get a life that we think. They wouldn't move away from home, they wouldn't get a job, they wouldn't, you know, start life. So that's an example of how we now, with the innovations we have, can actually work. But it of course, you need personnel, you need time, you need maybe medication. There are lots of things that you need as well, but we need to put this effort in, because how much money isn't that? And the life and the quality of life for that young man.
And I suppose that's why it's sad that Thomas, you know, the one who presented the health economics analysis earlier today, is no longer in the room, because that's where I think the health economics would really demonstrate the value of these kind of intervention, because we know that the cost downline, you know, in terms of treating obesity. You were saying the surgeries for the knees, the dialysis. So the cost of not treating obesity is so high that, you know, it was the investment, but again, it's a long-term thing.
We're sending a scale and hooking him up on the chat. That's it. Could it be cheaper?
Now we have to move on to the last topic that we have now, and that's about inequality and about socioeconomic status, and that it's closely linked to health, and with limited access or only privately funded alternatives for new innovations that could really even further divide the socioeconomic status in many countries. I don't know, Brian, do you want to start? You come from a privately funded
yeah, so, you know, the U.S. story is absolutely that if you have good insurance, you get the best health care in the world in many ways. I mean, if I wanted to send an email to my primary care physician today, I'd probably have a response within 24 hours to a question. If I wanted to meet with them online, you know, a few hours after that, I probably could get an appointment to do that. If I need to be tested for something, he could order the test. I could walk into a clinic, have the results in a few days' time. He could review them, prescribe a course of care. So that's kind of, you know, the best case scenario. But for many people, you know, they don't have that good of insurance that allows them to do that. And then for about 7% in the US, they just don't have insurance. Now, at this point, those are largely people who are kind of opting not to have insurance. It's not an affordability issue, but we don't mandate that people participate in the system. So but the truth is, when I spend a lot of time thinking about this in the context of low, middle income countries, because that's where the bulk of the population is, right? And how is it, we've read about the challenges we have, how it is that they, in their current context with lack of health infrastructure, how do we leverage technology to allow to empower people to have more information and make more decisions, but how are they going to reach the innovation what's on the highest shelf? We're far, far from that. Sorry, I don't have the solution for you, other than to say, when I go back to time and time again, it starts with developing primary care capacity. And I think what we've done is we've gotten the system so focused into kind of specialized, siloed care, and so de-emphasized, primary care where people can easily access and interact with and build a trusted relationship with somebody. And then, kind of take the next step here. I think in many ways the system has to devolve and democratize, whereby we're just making healthcare a lot more accessible to people, giving them a lot more information, and allowing them in some ways to kind of self-direct their care, supported by their technology. Because I don't think we've got the ability to build just multiple clinic after clinic and ask people to stand up in line for it. You tell me if you see it differently.
But I think you mentioned the difference between the US, Europe, and low middle income countries. I think we do not have. I agree with you, and we see the figures, and in the IDF Europe Atlas, it's staggering.
It's hard to get your mind wrapped around.
Indeed. But still, you have it within Europe, in Eastern European countries. The access to technology, basic technology, sometimes even insulin. Not to say about the new obesity drugs, etc. So I think you have that inequality in Europe, within the EU too. I think we saw it, in some of the presentations, but even within countries. And we know that a lot of the people, and again, people living with obesity and diabetes are way more likely to come from lower social economic background, lack of education, etc. So the inequities are everywhere. And then there are some policy barriers, for example, to access to some of the medication. I've heard recently, for example, that in Germany there is a law that makes access to GLP-1 to people living with obesity illegal. So it's not, a question of pharma company not filing or whatever, because I think this may also be an issue in some cases.
Why they wouldn't file, right?
But but so I think there are so many reasons for people not having access that again it's a lot of work to look into.
Yeah, and I see that we're soon running out of time, and I want to just have a final question for all of you, and that's if there's one thing you would like to change now. If you could go out and change one thing in the healthcare system or in the policy space tomorrow, what would that be? Who wants to start?
That's a big question.
Then I'm just pointing. Elisabeth.
I'm happy to do. So I think, and again, I'm very idealistic, is really to raise the level of health literacy in whatever way we can. And obviously, I come back with the CGMs, which to me is one way of doing it. But if we could think about, making sure that people are empowered and have the knowledge and then can leverage the knowledge with the support that they need, I think that would be a very good start.
Yeah.
Yeah, maybe go back to what we started talking about, that prevention has to be a part of care as well, and that we actually think about prevention not only in primary care, not only in schools, that it really should be part of our whole idea of society, that it's to in everywhere we should think about prevention. What can industry do? I mean, what can society and schools and primary care but also private companies, like we should all have that target, I think. What if we said, let's just decide that we in Sweden, our goal is that we're going to have the healthiest population. What if we all had that idea and everybody contributed? Now we're a little bit like, oh, that primary care can do that. And that's not targeting all the people.
Brian, a quick comment from you as
One thing.
That's the hardest one.
I think it would be a huge investment in community healthcare workers. So these would be people who would go into underserved communities, not necessarily doctors, but healthcare workers who would be working with people to develop, preventive strategies, being their kind of first line of care, really developing trusted relationships, empowering people to do more. I think that's where I could see, we talked about how to get to more about early focus. That's real. That would make a difference, I think.
Thank you. And that should be then the final words for this panel discussion. I think it's been a great discussion, and I'm really hope that these things can happen as well.
In time.
Thank you.
Thank you.